up front.
180!
3rd and 6. Haney's pass. Johnny Knox. Fumble. Ball's loose. And the Seahawks have the football. Earl Thomas came up with it after Johnny Knox caught it and lost it. And Johnny is down. Johnny Knox injury again. It was Chancellor who knocked the ball loose after the catch, but Anthony Hargrove, number 94, coming in afterwards. He slams head on with Knox.
And you can see what happens to Knox here as he loses the ball. Watch as he lays out, and then Hargrove going for it at the same time catches him right under the chin and just bends his body backwards, clearly in the direction, Chris, the body's not supposed to.
On 2nd and 5, plenty of time for Dalton. Was short of the first down on the catch by the rookie Josh Malone, 4th-round pick out of Tennessee, and Ryan Shazier, the leader of this Pittsburgh defense, is not getting up.
There with his head down, and that's never a good thing.
Spinal cord injuries happen often in football, but they are also commonly seen in everyday accidents, such as car accidents and falling down the stairs. During this presentation, we will give a brief overview of spinal cord injuries and then talk about how to work with people with spinal cord injuries as an exercise professional. Here's a short video overview of spinal cord injuries.
Injuries to the spine and spinal cord occur when the body is exposed to forces greater than these body parts can withstand. Spinal injuries result when only the bony structures and/or ligaments are damaged. Though the area affected will probably need to be immobilized until it heals, the spinal cord is not affected. When an injury involves the spinal cord, the flow of messages between the brain and the rest of the body is interrupted or cut off. This interruption results in a decrease or loss in movement and/or sensation below the level of injury. The higher the level of injury, the more the body is affected. The 33 vertebrae that make up the spine are separated into 5 groups. At the bottom of the spine, there are 4 coccygeal vertebrae. These bones are fused and make up the tailbone, otherwise known as the coccyx. Above these are 5 sacral vertebrae, called S1 to S5. These are also fused. Nerves from this level supply the pelvic region. The 5 lumbar vertebrae in the lower back are called L1 to L5. Injuries at these levels can affect leg and foot function. There are 12 thoracic vertebrae in the chest. These are called T1 to T12. Injuries at these levels can affect leg and foot function and the chest and abdominal muscles. At the top of the spine, there are 7 cervical vertebrae in the neck. These are called C1 to C7. Injuries at these levels can affect lower limbs, chest and abdominal muscles, as well as diaphragm, arm, wrist, and hand function. When damage occurs higher up in the spine, there is a greater loss of function. Injuries to the spinal cord are called complete or incomplete. A complete injury means that there is no transmission of messages beyond the level of injury. This results in no sensation and no voluntary movement below this area. An incomplete injury means that some messages are being transmitted. These messages can either be movement and/or sensation. Injuries to the spinal cord are also divided into 2 groups, paraplegia and quadriplegia. Paraplegia refers to the paralysis of the lower limbs and lower trunk, resulting from thoracic or lumbar injuries. Quadriplegia refers to paralysis of both upper and lower limbs, resulting from cervical injuries.
The nervous system is composed of the central nervous system, which consists of the brain and spinal cord, and the peripheral nervous system, or the nerves of the extremities. The body requires all these components to work together, so if there is an injury in the system, it can affect conduction of the rest of the system. There are a few different types of injuries that can occur. First is complete. This causes permanent damage to the area that was affected, usually resulting in paraplegia or tetraplegia. Next is incomplete. This causes partial damage of the spinal cord, and the ability to move and the amount of feeling depends on the area of the spine that was affected and the severity. Last is acute, which is a sudden onset of symptoms. If there is injury above C4, the person may require a ventilator. If there is injury at C6, they usually have shoulder and bicep control, but not in the hand or wrist. When injury occurs at T1, it usually affects the chest and lungs and results in paraplegia. Injury at T1 to 8, there is often control of the hands, but lack of control of the abdominal muscles. When there is injury at T9 through T12, it usually allows good trunk and abdominal control. And if injury occurs at the lumbar region, it generally results in some loss of function of the hips and legs. And if there's injury at the sacral region, it generally results in some loss of function of the hips, legs, ankles, and feet.
This chart was made by the American Spinal Injury Association and is useful in tracking which parts of the body have feeling and functionality. An exercise professional that works with many clients that have spinal cord injuries should familiarize themselves with this chart so they can look at it and know what their client is physically capable of doing. Exercise can help improve the quality of life in people with spinal cord injuries in many different ways, including improved energy levels, greater ability to take part in activities, increased strength, increased flexibility, improved mood and sleep, and decreased pain. But most importantly, exercise improves mobility and helps them to stay independent.
When testing people with spinal cord injuries, there are a few things to keep in mind. Like initial function should be assessed, including range of motion, strength, balance, transferability, wheelchair mobility, and upper and lower extremity motor involvement. This assessment will facilitate the choice of exercise testing, equipment, protocols, and adaptation. The purpose of the test should be considered in the level of completeness of the spinal injury. Also, the fitness level of the participant should be assessed in order to optimize equipment and protocol choice. Choosing an exercise mode that allows the greatest amount of muscle mass to be engaged is also important. Lastly, people with spinal cord injuries that require a wheelchair may develop joint contractures because of muscle spasticity and strength imbalance.
People who have suffered a spinal cord injury should perform aerobic exercise a minimum of 2 days per week and progress to 3 days per week quickly. Athletes should increase this to 3 to 5 days per week. Beginners should start at a moderate intensity of 40 to 59% heart rate reserve. Athletes may want to use a higher intensity of 75 to 90% of their heart rate reserve. Initially, bouts of 5 to 10 minutes with alternating 5-minute active recovery periods should be used. This can be gradually increased to at least 20 minutes per session and decrease or eliminate rest periods during this time. They should engage the largest possible muscle mass. This needs to be tailored to the type of injury that they have suffered. If they have some movement of their legs, something such as recumbent stepping or voluntary arm and leg ergometry could be used. However, if they cannot use their legs, it may be more beneficial to perform laps around a track in a wheelchair or just arm ergometry.
It is very important to empty the bladder before exercise and stay well hydrated before, during, and after. Heart rate is not an accurate measurement of intensity in quadriplegics, and in most paraplegics, RP is preferred. Oscillations in blood pressure may impair performance and can be life-threatening. And lastly, higher core temps and lower sweat rates reduce heat tolerance and should be considered. Resistance exercise should be done a minimum of 2 days per week, starting with 20% RM for each exercise. 1 to 2 sets of each exercise should be done each session, then gradually progressing to 3 sets of 8 to 12 reps. It is recommended to use dumbbells, cuff weights, or bands. Some considerations for resistance exercising include to avoid doing a lot of pushing motions and balance the pushing exercises with pulling exercises like rowing or lat pull downs. And strength training sessions from the wheelchair should be complemented with non-wheelchair exercises that involve all trunk stabilizing muscles. Flexibility should be done daily, but should not be done to discomfort. Each muscle group should be repeatedly stretched for 3 to 4 minutes per day, and preferably after warm-up or following an exercise bout. Active stretching is preferred, but low-intensity passive stretching may be used. Some flexibility considerations are: all muscles should be stretched slowly, especially spastic muscles, to minimize the activation of the stretch reflex. Stretch spastic muscles that may cause joint contracture, and increasing range of motion should be slow and based on pain tolerance. Some things in general to watch out for while training this population are any equipment that could potentially cause friction or pressure on the skin, as well as watching out for anything that might cause a response from a stimulation that might be painful or causing irritation leading to AD. Overuse injuries, spasticity, making it hard to maintain proper position and form, and lastly, if the individual is on medication, it may dampen their pain threshold, making it difficult to tell if an exercise is painful and possibly causing damage. Some common places that you might work with this population are a physical therapy clinic, a hospital or rehab, a gym, or in a group exercise.
A study by Hicks et al. Examined the effect of 9 months of exercise on strength, arm ergometry, and psychological factors in people with spinal cord injuries. Some of the exercises used to measure strength included shoulder press, chest press, and elbow extension. Psychological factors were evaluated using different surveys, including a 14-item perceived stress scale, the Rabausen and colleagues' 9-item body satisfaction questionnaire for their physical self-concept, and short-form 36-item health survey for pain. The study found that the exercise group experienced an 81% increase in arm ergometry power output, an increase in all measures of strength ranging from 19 to 34%, and the subjects felt that they were experiencing less depressive symptoms, less pain, less stress, and greater satisfaction with their overall health and quality of life. A major barrier to exercise for people with spinal cord injuries can be that they feel out of place. If someone in a wheelchair was to go to any random gym, they would most likely be the only person in a wheelchair there. A great way for those who have suffered spinal cord injuries to work out is through group exercise. Wheelchair sports are not only a great way to stay in shape, but they also provide the team atmosphere and sense of belonging that can provide extra motivation to stay in shape. There are many different options such as wheelchair rugby, basketball, and softball. When working with someone who has a spinal cord injury, it is important to carefully design the routine so that they are capable of completing all exercises. You should make sure to work out all major muscle groups that they are capable of, and incorporate functional exercises that can help them with their everyday lives. A good example of this would be dips. If someone cannot use their legs, they will mainly rely on their chest and triceps to move their body around. For cardio, some good alternatives to biking and running are arm ergometry and doing laps around the track in a wheelchair. To end the workout, the exercise professional should assist in stretching all major muscle groups. Even if the client does not have control of their legs, it is important to stretch the muscles because they can affect posture. Here's a video of an exercise professional working with someone who does not have control of their legs because of a thoracic spine injury. Another sport that this population can perform is wheelchair BMX. Here is an example. Due to technical difficulties, we do not have the rest of the video. But you can trust me, I definitely landed that jump. In the meantime, here are some actual tricks.
Backflips for breakfast, I guess.
We should give you like a shirt to wear.
Nah, it's motivation to land it. Is this real life?
To wrap everything up, exercise is both safe and recommended with this population. And when designing an exercise program, make sure that the client is able to perform all exercises, as it could be discouraging if you try to have them do something that they are not capable of. It is also important to keep your client motivated and encourage self-efficacy. The client is not defined by their disability, and exercise will help them to stay independent. In many cases, those who have suffered a spinal cord injury can have feelings of hopelessness as their whole life changed in an instant. As an exercise professional, you can help them in the road to recovery and help to improve their quality of life and independence. A great example of exercise and hard work is Ryan Shazier. Earlier in this video, we saw him suffer a spinal cord injury during a football game. In a year, he went from not knowing he could walk again to performing advanced exercises such as box jumps and deadlifts. Although not all people with spinal cord injuries will be able to achieve this level of recovery, exercise can still help them lead a better life.